Good afternoon, everyone. My name is Megan Miller. I am the Senior Director of Health Integration at ASTHO, and I'd like to welcome you to today's PCO webinar on behavioral health and primary care integration in rural and underserved areas. ASTHO, with support from HRSA, is providing this webinar to facilitate the sharing of best practices, address emerging issues such as payment and delivery reforms, and to foster collaboration and partnership among PCOs. Each webinar is 1 hour, and we'll have some time set aside at the end of this for discussion with participants and to answer your questions. So first, just a little bit of housekeeping. In an effort to reduce background noise, please mute your individual phone line during the presentation and when you're not speaking. Also, please do not place this call on hold. If you can, it does generate music usually, so we'll have to mute you. So please try to make sure your line is on mute and don't place us on hold. If you have any questions during this call, you're welcome to post it to the chat box, which is on your screen at any time. These questions will be answered during the Q&A at the end of today's presentation. We'll also open the phone lines during the Q&A session for you to ask any additional questions then. At the conclusion of this call, you'll be directed to an evaluation survey, so please take a few minutes to complete the survey, and we'd appreciate any feedback you have to help inform future ASTHO work with PCOs. Additionally, we'll be posting the slides and the recording of this webinar to ASTHO's website, and we can share that link with you when we conclude the webinar. So now I'd like to introduce today's speaker. So first we have Nisha Patel. Nisha currently serves in a dual role in the Federal Office of Rural Health Policy as the Community-Based Division Director and Acting Associate Director, Senior Advisor for the office. In this role, she provides oversight to the management, operations, and fiscal responsibilities for the Community-Based Division and advises the Associate Administrator of the office on a wide range of issues. In her spare time, Nisha stays busy being a mom with 2 kids who are 4 and 3 years old. Next, we also have Alex Ross. Alex is the Senior Behavioral Health Advisor in the Office of Planning, Analysis, and Evaluation at HRSA. In addition to focusing on behavioral health workforce programs, Alex supports HRSA bureaus and offices fostering the integration of behavioral health and primary care. Dr. Ross's work has included an emphasis on financing issues regarding behavioral health and primary care services and ensuring that an appropriately trained healthcare workforce is available to meet the nation's needs. In addition to his current work, Dr. Ross has held positions at HRSA in the Bureau of Health Workforce, Bureau of HIV/AIDS, and the Office of Public Health Practice. He has a Doctor of Science degree in Health Policy from the Johns Hopkins University School of Hygiene and Public Health. At this time, I will now turn it over to Nisha.
Great. Hello, everyone, and thank you so much for having me on the call today. And I'm looking forward to talking a little bit about behavioral health in rural areas, some of the key data points that we are seeing right now, and then some of the activities that we have going around this issue. And I think, as you all know, this is just a very important topic right now at the local, state, and national levels. And there's a lot of activity going on around it, both on the policy side and the program side. And really now more than ever, you're hearing about behavioral health being such a hot topic because of sort of all the research that's out there, the data that's out there, and really the challenges that, in particular, rural communities are facing, and with folks accessing behavioral health services, but also just other challenges that communities are facing as well. The emphasis really at the federal level, as you'll see, really focuses in on the administration's focus on this issue, and then also the Department of Health and Human Services work, particularly around the Opiate initiative, which we'll talk a little bit about. In terms of policy in particular, Medicare is really encouraging the integration of behavioral health by allowing for same-day billing for mental health and primary care services, and Medicaid is also really starting to make strides in the integration of behavioral health with many states to also allow for the same-day billing of services. And then there's also the Medicaid mental health parity that was published in March, which this rule strengthens access to mental health and substance use disorder services to Medicaid and CHIP beneficiaries. And so there's a lot of work going on around in the policy arena in particular. When you look at some of the data points, and these next few slides are really sort of data heavy, we know that nationally approximately 25% of all adult stays in the United States are related to behavioral health. And then, of course, when you look at rural communities and underserved communities in particular, You think about the stigma that rural communities face around accessing behavioral health services. We see people who are not seeing doctors for their illnesses. And so really as a nation, we're struggling with how to educate people and shifting sort of the mindset of mental health being a disease and not something that someone should be ashamed of. And so I think that's really a huge challenge right there that as a nation we're facing. In rural communities, we see it, even more so because of the nature and the size of the community and the stigma that is associated with it. Rural communities are also facing a number of challenges in accessing mental health services. In addition to the stigma, you think about the geographic challenges, the transportation challenges, and then the shortage of providers. And then there are a number of unique prevalence factors as well, where 20% of rural residents, 55 or older, have a mental health disorder and poor health status in rural communities. And so the obstacles are significant with the need to expand availability, accessibility, affordability, and really acceptability of all the services that are out there. Suicide is another, really obviously important piece of this and such a huge issue in rural communities. Research tells us that people are visiting their primary care physicians instead of a mental health provider for mental health problems in rural. And so up to 88% of patients who die by committing suicide have had contact with their primary care physician at some point during the year prior to their suicide. And when you look at some of the research that's out there from talking to primary care physicians, we know that the need for public education to make the community aware of warning signs and methods to respond to high-risk individuals is critical. And we're also seeing the importance of educating schools and teachers and everyone else really involved in people's lives and taking care of their overall well-being. We're starting to see a lot of integration between primary care and mental health in general, which is obviously important, and providing doctors the expertise that they need. And again, going back to the stigma in rural is great and significant, and there are people who are not seeing doctors for their illnesses. And so again, thinking about what can we do in rural communities to help address some of these challenges. And then there's the opioid epidemic, which I'm sure you all are pretty familiar with. It's in the news really on a daily basis. And again, as a nation, it's something that we are facing and really in the midst of a crisis is the opioid epidemic. And here's some of the key data points that we're seeing around this. Since 2002, the rate of the drug overdose deaths has increased significantly. In 2014, opioids were involved in close to 30,000 deaths. And when you look at the number of percentage of U.S. physicians who have obtained a data waiver to actually prescribe buprenorphine, which obviously is really significant, is only 2% of U.S. physicians. And then more than 30 million Americans living in counties without access to buprenorphine treatment. 82% of these counties without a physician who could prescribe were in rural areas. And so, when you think about some of the reasons in terms of why we're having physicians not obtaining the DEA waiver, a lot of this has to do with the time and the burden that it does take to apply for the DEA waiver. But when you look at rural communities in particular, and a lot of what we hear is, again, we hear from folks that we talk to that the reputation of being known as an addiction clinic really is a challenge for people and for physicians. And so it really deters them from taking the opportunity to get this waiver to be able to prescribe buprenorphine. And then there are also potential liability issues as well that rural communities are facing. And so just some more data points around this, around the opioid addiction in particular, 45% higher in rural than urban. But yet when you look at the use of naloxone, which is the drug to reverse the effects of an opioid effect, the use of a naloxone by EMS staff was only 22% higher in rural than urban. So you think about the availability of naloxone in rural, the resistance of law enforcement and others actually wanting to use it, and then the signs of overdose. And so these are a lot of things that rural communities are having to really focus in on right now is how can we educate our law enforcement? How can we train the providers and law enforcement in the use of naloxone? How can we increase the availability but also the accessibility of naloxone so that, rural communities are well equipped to be able to handle this epidemic. And again, rural communities face a number of prevalence factors. We have an older population, low-income families, and then heavy labor occupations such as mining where painkillers are prescribed frequently. And then there's fewer options that, rural communities face, including a shortage of psychiatrists in rural. There's a lack of detox centers. And going back, that only 3% of primary care physicians have received a waiver to prescribe buprenorphine in rural. And so these are all significant challenges that we're facing in rural communities, and thinking about ways to be able to address them. The lack of detox centers is significant because when you think about rural communities and the fact that there are a lack of providers, a shortage of providers, and a lack of detox centers, and then sort of coupling that with the fact that if a patient needs to get to a detox center to take, their methadone pill, the transportation is a challenge as well, and the distance to get to the detox center is a challenge. And these are all sort of significant, unique challenges that rural communities are facing on a daily basis. And then when you look at sort of where we're seeing the opioid overdose deaths right now, there's a lot of studies out there that are, talking sort of about what states we're seeing them at. We see that rural states are more likely to have higher rates of overdose deaths, particularly in the Appalachia region, which is, significant when you look at West Virginia and Ohio with some of the rates there. And then we're looking at women are dying more, even though rural men are using more. We're seeing rural women dying more. So when we talk to our grantees, we're funding grantees to work on a lot of this, behavioral health just in general, mental health services and opioids, and sort of what we're hearing about their challenges and what they're sort of just overall thinking about. They're talking a lot about the integration of behavioral health into primary care, really thinking about the reimbursement piece, which is significant. Workforce, obviously, which we touched on with the shortage of providers being so significant, and then the opioid epidemic and suicide rates. And thinking about what some of our grantees are doing that are helping to address some of this in sort of innovative ways. Because when you think about rural communities being successful in implementing a program, there's so many factors that go into it. And a big piece of it is the collaborative piece. How can you make sure that all the key partners in the community are coming together to be able to successfully address this problem? And so you're looking at your providers, but you're also looking at social service agencies, being able to serve as a partner as well. And so particularly around mental health and substance abuse, it's important to think about how we can make sure that there's a linkage between the two. And that's what we're starting to see with our grantees as well, really this generational bundled approach. With the opioid crisis in particular, we have a couple of neat projects that are going on. One up in Maine that's specifically targeting tribal communities, who has recently just created a patient education video and has gotten clearance, and they have it on their website for Native Americans in particular, prescribed on how to respond to an overdose. And so now we're targeting, the parents and other loved ones of someone who may be struggling with an addiction, and making sure that the family feels sort of well-equipped and able to address an overdose if that ends up occurring. And then we also have a grantee up in Ohio where their partnership includes a number of mental health organizations, and they're really focusing on training providers and family members on how to recognize overdose signs, but then making sure to distribute the right Narcan to their first responders and their loved ones of the high risk. And then the circle of care, which is so important, particularly in rural communities, again, looking at how small it is to make sure that you're able to sort of develop this trust and, have this sort of team-oriented care delivery approach when it comes to providing care to the patient. And then just another example here of Maine that, again, talking about the integration of behavioral health into primary care and the utilization of peer navigators in doing so. So establishing the trust with patients, connecting patients to care, and then, as I mentioned before, sort of having the social services aspect involved as well is extremely important. And so the peer navigators here are working with people to help make travel arrangements, child care arrangements. So they're making sure that all of that is covered so that the individual can get the care that they need and feel that their family is being supported while they're getting the care. And I think that's what's been so it's been standing out to us as we're talking to rural communities. That's been extremely important, is that they hear from individuals how hard it is to get the care that they need and take the time out of their schedule to be able to go to counseling appointments, inpatient or outpatient, when they are worrying about their children or their families back home. And so it's important, again, going back to sort of that collaboration piece, particularly in rural communities, to be able to link the two together. And then just some of the ways that, some of the stuff I'm talking about with our grant programs, here are really our primary grant programs that help us do that. And so we've got a number of grant programs. You see one that's really sort of telehealth focused, which obviously with the shortage of providers in rural, our telehealth programs are extremely important in helping to bridge the gap between sort of the rural and urban communities being able to come together, work together, but that making sure that the patients don't feel like they are not getting the care that they need. And so that plays a significant role there. We have our outreach program, which provides direct healthcare services to rural communities, and then our network programs that are very much focused in on infrastructure development and capacity building in rural communities, which is really important to be able to effectively deliver high-quality care. And so, in any given year, one of these programs or more are competed, and rural communities have the opportunity to develop a program and implement a program around any topic or any issue in their community that they're struggling with, continuously on an annual basis when the programs are competed. Mental health and substance abuse are always among the top 3 of the proposals that we're receiving. And so we continuously see that it's a challenge in rural communities, but we're also seeing that rural communities are finding ways to come together, work together, and implement innovative strategies and approaches to help address that in their community. So some of the things that, our folks in rural communities in general that, we talk about considering when they're putting a program together, particularly around behavioral health, is thinking about the needs assessment. Who else in the community is addressing this issue and how can they work together? What are some of the available resources that are out there? And then how are primary health and behavioral health interacting currently within the community or in the state? Looking at the statewide initiatives that are out there, who's already working in this arena that's doing well, that's a champion that can provide insight or lessons learned or even potentially collaborate on this initiative. And so sort of thinking about all of that and thinking about who to use as peer staff. I think what's so important, particularly in rural, is developing that trust with the individual. And so whether that's through the use of a navigator or a recovery coach or whoever that may be, it's someone who can really relate to the individual, can understand where they're coming from, takes the time to know the individual, but their family as well, and then develops a trust with them. And that's significant in rural communities. And so we continuously see that over and over again with our grantees, making sure that someone who may not necessarily be a provider is the person who is directly working with the individual on a daily basis. And then we've also developed some tools around behavioral health in general through the Community Health Gateway. And this is a website that is off of the Rural Health Information Hub, which is housed at the University of North Dakota, and it's funded through us through a cooperative agreement. And through here, what we have done over the past few years is developed an evidence-based warehouse, so really recognizing that rural communities are looking for resources as they implement programs in their communities, and they want to implement programs that obviously are going to be impactful, but that can demonstrate outcomes as well. And so this has helped us to do that. And so from this website, we have developed a series of toolkits and that we're continuously doing on an annual basis. And so we have a toolkit on mental health that we were able to post last year. And so when you go to this website and you look at the toolkits that we have, we've got a number of toolkits on community health workers, obesity, oral health, services integration, mental health. We're currently working on a toolkit on addiction that's going to be coming out, I think, later this year, if I'm not mistaken, or early next year. And so these toolkits are meant to be a resource. We're developing them through comprehensive literature reviews of models around the country that have been proven to work and have been impactful, taking from them and putting them into sort of self-learning modules. And so, for example, our community health worker toolkit will touch on how do you recruit a community health worker? How do you retain a community health worker? How do you train one? And pulling the lessons learned from there. So that really ties into our mental health one. There's a care coordination one. They're all very closely aligned and very important and a valuable resource for rural communities. And then just a few more resources to note. You know, SAMHSA obviously has a number of resources. We are doing a lot of research on behavioral health right now. We have done a lot of research through our research centers and are continuing to do so. This gives you a sense of our funded research and then really focusing in on our behavioral health topics. And so these are funded through our office, and the ones that are in progress, once they're complete and the brief has been approved, will be published on the Rural Community Health Gateway. And I just noticed the website's not on there, so we can make sure to get that to you. But if you just Google Rural Community Health or Rural Research Gateway, it will pull up all the research centers that we're funding and their projects as well. And these are really great because, you know, they're sort of like, what's the latest research around a particular issue in rural America? And so how does the data look right now? And putting together a brief that can be very valuable for communities looking to address a specific issue. And again, just some SAMHSA data points that may be valuable for you all to look through. And that's it on my end. And so I think we're going to do questions at the end. But Alex, I will hand it over to you to talk about sort of the agency-wide initiatives.
Yeah, thank you, Nisha. That was outstanding. I mean, I work here, and I'm amazed when I see these presentations, all the terrific things that are going on. And you know, thank you to the Office of Rural Health Policy for the incredible work you do. Also want to thank Megan and Emily for the opportunity to spend a little time with you all today, and to my colleagues here in the room, Lynette and Karen, who work on the No Slow ASTHO project. So thank you all for your efforts. It's a pleasure to be with you, to my colleagues in the primary care offices around the country. And when I talk about our work here on integrating behavioral health and primary care, I want to make sure I frame it with a sense of what you do in your PCOs and try to give you a little sense of how our work can support the things you're doing, and this information can be useful to you as you interact with other state-level colleagues and safety net providers around the country. So in a moment, I'm going to go through a little bit about HRSA's profile on behavioral health service delivery, so you have a sense of broadly in our grant programs where we're placing emphasis on behavioral health integration. And then I'm going to conclude with a discussion of the work going on in the SAMHSA Center for Integrated Health Solutions, where we have a lot of terrific tools and training materials that could be very helpful to you in your work. So we'll go on to our next slide here. And again, a sense of HRSA and our mission, which I think you know so well. So we'll go on to our next slide. And as well, you know, the areas in which we have our investments in behavioral health. And I'm going to go now into a description of each of these. But first, a little more on the overview of the agency, and I think you may be pretty well aware of the reach of HRSA and our grant programs. But we are, as you know, the agency that's concerned about making sure there's access to care and a qualified, available workforce to provide those services. I think that's a mission that PCOs and HRSA share. What about behavioral health integration in our health center program? Serving over 24 million people in this country in the communities that most need those services. Over 80% of the health centers now provide some level of mental health services directly on site, and approximately 20%, 21% are providing substance abuse counseling and treatment on site. The only the only caveat here, and again you know this, is there'll be some diversity in that service delivery in different parts of states. They may have more access through the health centers than others, and the available workforce will obviously differ from health center to health center. At the bottom of the slide, you'll see that there are over 7,700 behavioral health professionals, providers working in health centers today. Again, the distribution will differ, but these are comprehensive provider organizations making sure that we have access where most needed. You may be aware, I hope you're aware, of the expansion efforts on behavioral health integration. I think the health center program is moving the dial in a big way on building that behavioral health access. Within the last 2 years, the Bureau of Primary Health Care had 2 supplemental awards to build capacity. One, the Behavioral Health Service Expansion Grants, and they're listed in this slide, and the other, the Substance Abuse Services Expansion Grants, which were more recent and have an emphasis on medication-assisted treatment. This is an intent to both build workforce availability and, where that's not possible, to make sure that services are provided in communities and that there's a really strong link between the health center and those other provider organizations. We'll go on to the next slide. And the National Health Service Corps program, which you work with very closely, has a big emphasis on building that behavioral health workforce, again, in HRSAs and in MUAs. Here's a description, and you know the types of providers who are eligible for scholarships and loan repayment through the National Health Service Corps, the behavioral health professions that are covered. And I think the really interesting thing to me about the National Health Service Corps and what they're doing to make sure we introduce the next generation of behavioral health professionals to working in communities that most need them is the statistic about the percentage of loan repayers and scholars who stay on in their communities after their commitment is completed. And to me that says, you know, if you expose a future practitioner to the safety net setting, then you've got a good chance of getting them interested to stay for a period of time and make a contribution. To me, that's really encouraging. Next slide, please. So what about our health professions, workforce, and training programs besides the National Health Service Corps? And these are programs that engage in medicine, nursing, behavioral health, and public health training and education across the nation. One good example is our Graduate Psychology Education Grant Program, and a second one is the Behavioral Health Workforce Education Training Programs. What these programs have in common is a focus on integration and the multidimensional workforce, making sure that practitioners are working across disciplines as a team, and exposure to field placement opportunities during training and education, field placement in integrated care settings, so that these future behavioral health providers will see the value of practicing in the primary care settings as well as specialty behavioral health settings. What we do find is if you have a behavioral health provider who's been trained in a traditional model of behavioral health service delivery, when they do integrate into primary care as part of a team, there can be an adjustment. If you've trained that individual early on in their education to work as part of a team, to understand the value of the integrated care setting, then you have a good chance that they'll find that as an appealing place to practice. I want to emphasize the AHEC, or Area Health Education Centers program. Terrific opportunity to do continuing education on behavioral health integration. And finally, just to note that the National Center for Health Workforce Analysis here at HRSA has a new grantee that focuses on the behavioral health workforce and doing a lot of work on enumerating what that current workforce is, what are the disciplines, what's the scope of their practice across the states. This could be a terrific resource for you in the years to come. How about our Ryan White HIV and AIDS program? Well, a profile that's somewhat similar to the level of service delivery in the health center program. 3/4 of the HIV provider organizations provide mental health services, and approximately 1/3 are providing substance use disorder treatment services. It's a really important relationship here, the HIV and AIDS provider organizations, because both mental health and substance use disorders are a risk factor for HIV, but living with HIV or AIDS can also be a risk factor for either mental health or substance use disorder issues. And so this is a multidimensional, complex relationship. Integrated care can be particularly important in those settings, and our Bureau of HIV and AIDS is recognizing that and trying to address that. I want to point out the journal article, Medication-Assisted Treatment in J-AIDS. It's a wonderful 10-year study that showed in Ryan White-funded clinics, medication-assisted treatment is quite doable, but one of the key components to that is having a nurse care manager or other professional who's playing a care coordination role. And so we've learned a lot, and I think Nisha touched on this, about what makes opioid abuse treatment work in primary care settings. Things like having a really good care coordinator is critical. And our maternal and child health programs, the block grant and the program itself serving over 500,000 or more individuals in this country, mothers and children. The work that we're doing around integrating behavioral health into those maternal and child health settings is absolutely essential today. Young individuals, young children, and then adolescents and transitional age youth, these are critical times to make sure that individuals have that access to both mental health and substance use disorder treatment services. And you will see a number of key programs that you're probably familiar with. Our Healthy Start program for high-risk pregnant women. The home visiting program, which is now available in every state in the country in various communities. A strong emphasis on screening and brief intervention early on in homes to recognize a behavioral health concern and effectively refer out for community care. And another piece, which I think gets overlooked sometimes, is the Bright Futures. And that's what we call a periodicity screening guideline. And so providers use it to identify what the periodic screening needs are for the children that they treat. They have two very strong chapters, one on mental health, one on substance use disorder treatment issues. And many states in their Medicaid programs, in their EPSDT program, refer to Bright Futures as the guidelines to meet the expectations under EPSDT. And I'm not going to spend too much time on the outstanding presentation that Nisha gave, but you have maybe some other resources here that she covered or did not cover in her presentation that you could look at a later time. And as well, the really important work that the Office of Rural Health Policy did this past year using naloxone in community, building infrastructure and community-wide initiatives around naloxone. I know that I'm looking forward to what's going to come from the grantees in that program, the 18 grantees, when they share more of the materials that they've developed on explaining the value of naloxone, on the lessons they learn, and the achievements of those programs. I think it's a really critical initiative. And to remind ourselves, and I think you're well aware as PCOs, of our 10 regional offices and the partnership that they can have on your behalf looking at behavioral health integration in primary care. Each of our HRSA regional offices has a behavioral health lead, and I hope you've had some interaction with them in the past but they can be terrific in terms of information and also helping collaborate when you want to do specific initiatives around behavioral health integration. I want to finish up for just a couple of minutes on the SAMHSA HRSA Center for Integrated Health Solutions. I'd like to think that everybody on this call knows about the center and has availed themselves of the tools and training materials at the center. But if you haven't, after today's call, I hope you take a couple minutes to look at the website. This is a center developed by SAMHSA and HRSA approximately 7 years ago with the strategic intent of supporting efforts to build bi-directional integration. And what we mean by that is that SAMHSA, on behalf of behavioral health organizations around the country, has a real need to build primary care capacity in those entities. And HRSA has that reverse need. We're trying to make behavioral health services available in primary care settings. Between the two of us, we hope to achieve a no wrong door approach to care. Wherever someone comes for care, they should be able to get the services that they need. This center provides the training and TA to support the efforts to do that. And I think for the PCOs, there are terrific tools and materials that you can make available to others when they come to you and ask questions about integration and you want to refer them to a good TA source. I hope you'll see the center as that source for technical assistance. What exactly does the center do? Well, I was really pleased when Nisha talked about the 2 items in red. And no, we did not coordinate our presentations, but we have 6 major categories around integration that the center sort of operationalizes its tools and its trainings. Models, workforce, financing, clinical practice, operations, and health and wellness. And my mantra about integration is that if you don't have that effective workforce either on-site or through telemodalities and you aren't getting reimbursed for your services, it's really hard to get to that level of integration that the organization may want. But when you have that workforce and you're reimbursed for those services, then you know you can build those models, your clinical practices can rise to the level that you're looking for, your operations, your health and wellness, all of that comes together. We have critical issues that we need to make sure we're supporting the HRSA grantee community to achieve integrated care. On the next slide, I'm going to start talking just for a couple minutes before we take questions on specific tools. And I'm highlighting a few here. Again, I hope you're familiar with some of these, but our tools are all about practical information to get started on integration or to take it to the next level. And speaking of which, that item in the middle, standard framework for levels of integrated care, that's exactly the kind of conceptual framework that helps organizations know where they are on a continuum of integration for the from the collaborative care from a distance where 2 organizations do not have a business relationship. It's strictly a referral model to an on-site co-located model where 2 entities are in the same physical area, but they may not be the same organization. Maybe they're on different floors in the same building and they're able to interact because of that, to the fully integrated model of care, where it's one organization, it's a seamless electronic record, it's a behavioral health provider that might come in the exam room before the nurse practitioner or the doctor or the PA and ask the patient, you know, I noticed in your medical history today that you've been drinking a little more than you have in the past. Is something going on that maybe you'd like to talk about? And, you know, with that, doing a brief screen or suggesting that they follow up after the engagement with the primary care provider. This kind of model, you know, is one in a spectrum of options for delivering integrated care. The standard framework helps you to understand those different levels in the continuum. The core competencies document is, I think, particularly relevant in your roles as primary care organizations. We have come up with 9 areas of skills that are essential to do integrated care. And what's particularly important about this document is those are not 9 areas specific to any one profession. These are the 9 core areas. Different professionals will use those core competencies to a different extent. The family doc may be looking at 3 or 4 of those core competencies on integrated care. The nurse coordinator may be using some of the other ones, but these are the 9 that cross over every profession, and there is detailed explanation of what those skills involve. The Quick Start Guide is a wonderful guide that walks you through the ways to get started down the path of integration and which of the other tools at this website can help at every point in that continuum. A couple of other resources I just want to point out. I'm not going to take a lot of time because we do want to move to the questions, but an important piece on telebehavioral health that speaks to our friends working in rural areas, a listing of date-specific provider trainings kept up to date on opioid abuse provider training. We list all national trainings that we can identify at this on this website for anyone to access and then to find out more about the actual training. What makes for an effective behavioral health and primary care team? And then the final set of documents that I want to highlight, billing and coding worksheets. There is a worksheet for every state in the country at this website. It's up to date within the last 12 months that identify which codes for which payers for which types of providers. If it's the state Medicaid program in a particular state, how do you bill for behavioral health services? If you're a primary care provider, is same-day billing allowed? Nisha alluded to that before. We have the Medicare codes as well. And let me reemphasize on the same-day billing issue, which is the ability for providers in an organization or for an organization to bill for a behavioral health and a primary care service on the same day. There is no federal prohibition either in Medicare, where it's clearly identified, or on the Medicaid side. Some states may choose to limit which providers can bill for which services. In that instance, that's something that providers can make a business case for, a return on investment, and work with their states to see if they can change the current policies. And in fact, that's what the final document on this page is all about, return on investment for individual organizations. Finally, you'll see the date on this, August 25th. That was only a couple of days ago. It's about how to do effective benchmarking. It's a wonderful example of the webinars that we produce through the center. And benchmarking is a really critical tool for organizations to track their priority issues in integrated care. How are they doing internally, and how are they doing in reference to a comparison group? And this webinar walks through the steps to do effective benchmarking. All of the webinars are archived and available at the center. So a list of resources for you, similar to what Nisha talked about. And with that, I just want to open it up and see if we have questions. Megan, Emily?
Thank you, Alex, and thank you so much, Nisha, also for your presentations. They were excellent. I will open everything up now. If you have a question, you can write it into the chat box and or unmute your line and ask the question. And I think we have one, actually. So let me read it to you. Nisha mentioned during her presentation that rural men are abusing opioids more often, but rural women are dying more from it. Is there a reason for this? I would think men would be dying more than women.
Yeah, and it's so interesting because the data points there, and they're still, and Alex, I'd be interested if you have more information on this, but we're still looking at the research as to why that is the case, so I don't actually have the answer to that right now. Alex, do you know by any chance?
No, but I think one of the important things is that we're able to connect important questions like this with the answers. And so we have colleagues in other agencies around the department like SAMHSA and like National Institute for Drug Abuse, where we can get the information and then send it back through ASTHO and get you the answer that you need. It's a really terrific question.
Thank you both. Any additional questions? I do have a question about the slides, and we will post these online, and we can share the link with everyone that registered for the webinar. So they will be posted on our website along with the recording, so we will do that. One additional question. Alex mentioned the billing coding worksheets. Does this have billing information for rural health clinics?
Well, thank you for that question. To be honest, I think we focused for the primary care side on health centers, but what would be doable is to take the model for a particular state and then go to the state Medicaid agency and say, look, here's the way it is for the health centers on the primary care side. We'd like to know, are these the same codes that you use in a rural health clinic, or which are they? And I would assume there's going to be a fair amount of crossover between the rural health clinics and the health centers, but if there's some divergence, the Medicaid agency can identify it. It serves as a really good model to have that conversation with the Medicaid program.
Thanks, Alex, and thank you, Nordia, for these questions. Does anyone else have any other questions? You can unmute your line now or type it into the chat box again.
I have a question. This is Lynette and I have a question. Alex, you mentioned that the core competencies for integrated behavioral health and primary care, that there are 9 areas of essential skills.
Yeah.
Do you know, can you just...
Well, okay, so we'd have to go to, the website, and on certain presentations I've used the website directly and done this kind of live navigation, but I can say this, that what's particularly useful, and I'll share this with our friends from the PCOs, is those 9 competencies, they reflect a wonderful set of areas for a position description, for example, so that organizations that are saying, gee, I'd like to build this capacity, I don't have a lot of experience on integration per se, or building a behavioral health workforce, what am I particularly looking for in that skill set? And so you would be able to pull right from the 9 competencies. The center also lists model position descriptions, which can be also quite helpful to organizations building the capacity. And along with what Nisha mentioned about the resources that rural health has provided, the center will do phone triage. So anybody, a PCO or anybody that you refer to the center, can call with a question and have a discussion and get their question answered right on the phone.
Oh.
Yeah.
It's a wonderful resource. Mm-hmm.
Well, let me also say, this is Alex again, just because we want to make sure everyone knows about all available resources, AHRQ is doing terrific work on integration. They have an integration academy, and I highly recommend their website. And so what you end up with is a wealth of information, and it takes a little time to learn about every useful tool that's out there, but it's well worth the effort. So ARC is doing some good work in this arena. And our friends at CMS, through their Innovation Accelerator program, the IAP, focused on integrated care and substance use disorder services in the last 2 years, helping states build this integrated care capacity. I think we're seeing a real sea change in the focus on integration.
Additional questions from the audience? Here's one that we have for you. How do you think telepsychiatry could align with behavioral health integration efforts in rural areas? And I know that, Nisha, you mentioned telehealth and FRHP, but any other thoughts on that?
Nisha, did you want to respond first?
Sure. So, I mean, I think, overall, when we're kind of looking at what's out there right now, there's a lot going on around mental health and substance abuse, but there's a lot going on around telehealth just in general. I think when you look at rural communities and underserved communities, telehealth, telepsychiatry is extremely, extremely important to be able to have the capability to do so. The shortage of providers is significant in rural communities, and so we know that there's an opportunity for rural communities to be able to sort of open up access and have their patients receive the care that they need at a center that's close enough for them via telepsychiatry. And that's really important for an individual so that they don't have to travel too far of a distance to receive that service. And so a lot of what our office does around the programs that we have and the resources really allow rural communities to be able to get the funds that they need so that they can get the equipment that they need and then start that collaboration process, which is, again, is so extremely important between organizations so that they can have that capability set up.
And I just add, this is Alex, to that really very comprehensive response. There are a couple examples that make me feel like we've got something to work with here. In the maternal and child health community, there was the Massachusetts model for telepsychiatry consultations, which has a good evidence base to it, and I think clearly applicable in a rural setting, which showed that you can have brief consultations between a psychiatrist and a practitioner in the room with a child, and would give that family provider or internal medicine provider or pediatrician the kind of support they need to continue themselves with the care of that individual. And the second thing is work going on in Washington State, where they are using telepsychiatry with health centers in rural communities, and they are building up the evidence base about whether and how that works. Do you mind, Megan, Emily, if I ask Nisha a question?
No, not at all. Go ahead.
So, Nisha, Alex here. I might be catching you off guard. This might be a tricky one. How does integration in a frontier area differ than other aspects of rural areas? Are we looking at that in particular? Are there special needs in frontier?
So we haven't done anything specific, sort of looking at what the gaps are, or what the challenges are, but they are very closely aligned. I mean, we have grantees that are in frontier areas, and we've obviously got a number that are technically in rural areas, and the challenges are very, very similar. And so a lot, again, is on the reimbursement, the stigma with the issue overall. I'm sorry, I had someone just come in my office. Being able to make sure that you get partners on board, distance, the geography, transportation, all similar challenges between both.
And I think it was the telehealth piece that kind of triggered that in my mind. Is I'm thinking that in frontier areas, telehealth is probably going to be even more important as the way to get those services delivered.
Very true. Yeah.
Any other questions from the audience? I don't see any in the chat box. One more question from us. What are the strategies for evaluating primary care and behavioral health integration that you might recommend?
Ooh.
So, Alex here, I'll throw a couple things on the table. Nisha, maybe you have as well. First, there's really good assessment tools. How am I doing on my integration efforts? And when I talked about the framework for integration having 6 levels, there's assessment tools that mirror those 6 levels. So along the path, you could do a reality check. How am I doing, and where do I need to work harder to build that capacity? The second issue is, what are we measuring? And this has really been a challenge as we develop integration. Are we measuring the ability to provide behavioral health services just specifically, or are we measuring some aspect of integration that leads to better outcomes in those services? And NCQA has developed great performance measures around behavioral health, and one of the guides that we have at the center is how do you build those behavioral health components of the NCQA primary care medical home into your primary care setting. So we have a whole guide to describe that. Good work has gone on at the AIM Center in Washington State, University of Washington, to evaluate, does integration work? And there is a good evidence base, a number of meta-analyses that have been done. There are a couple of models in particular that have proven to be very effective. The challenge is fidelity to the model. So the concepts are good, it's the application, and ultimately it's the sustainability. And my work these days, I'm focusing a fair amount on how do we make sure organizations can continue with their integration efforts after the first year, because there are challenges that come up during that year. We have to make sure they can get over those hurdles. So evaluation is a really important question, and we can share with our friends at ASTHO some of those meta-analyses that talk about what works in integration.
Yeah, and the toolkit, I sent this link to everyone on the World Community Health Gateway, and when you look at the mental health and substance abuse toolkit that's on there, there's a whole section on evaluating programs that has been taken from, behavioral health programs that are out there, and I think that will be really helpful for folks. But it's really, what Alex talked about, how can you make sure that you're measuring the program and being able to really think of measures that can help determine the success of the program, but then even throughout the course of the program, how are you evaluating it so you can continuously make improvements to the program, and I think that's really important as well. Really thinking about, is the program being implemented as it was intended? Is it reaching the target population? What are some of the barriers to implementing the program, the actual outcomes? So really thinking all of that through and how they're relative to the program's goals and objectives is important.
Great, thank you both. And one other final question, because I don't see any in the chat box, and unless I'll give one moment for anyone who wants to unmute themselves and ask a question. Okay, so one final question from us. Thank you for the examples. I know you've given several in your presentations and related also to the telepsychiatry. But would there be any other best practices generally for implementing primary care and behavioral health integration that you've seen in states or locally that you want to share?
Well, this is Alex, and I'll end with this. It does come down to leadership, and it comes down to buy-in. And so it's not sometimes as complicated as which model or how many components to the model, and are we professionally capable of doing integration? You know what? A good provider organization with qualified professionals, they know what they need to do. They've been well trained. Sometimes it's a matter of getting the leadership, the board for that community-based provider organization, and support within the community to build this capacity and to make it work. A lot of the times when there's a step forward and then a step back, it's because leadership didn't invest completely, or there was a change in leadership, or individuals left the organization, and now we're starting with a new team. So it's a long process. It requires a vision about a long-term goal and outcome here.
Thank you for that. Well, I think we have just a minute left, so I'll go ahead and sign off. Thank you all for joining us, and thank you, Nisha and Alex, for your presentations and the resources you've mentioned, the links that you've shared. This is really helpful, and like I said, we will post this online at our website and share that with everyone who's registered for this webinar. One more thing, there is contact information on the screen if you have any questions, and just another plug to please fill out the evaluation survey at the conclusion of the webinar and let us know what you think and what we could do to make things useful in the future. And thank you again, Nisha and Alex. So thank you all. Have a great day.